Hello everyone, and welcome to today's Lunch and Learn, Diabetes, What's New? I'm Peggy Schmidt, and it is my privilege to welcome you as North Kansas City Hospital's President and CEO. Thank you so much for joining us today. Diabetes affects nearly 10% of the adults in Clay and Platte counties, or about 34,000 people. While we're slightly better than the Missouri average of 11.5%, we know that there are many more individuals who have diabetes but have not yet been diagnosed. And so we want to help spread the word and educate so that everyone can have the advantages that are available through wonderful physician guidance and diagnosis, and through some additional lifestyle changes, make sure that we do all we can to manage our health, including diabetes. I am very excited that we have Dr. Michelle Orr, an endocrinologist with Meritas Health, here to speak with us today about this common yet very serious condition. And Dr. Orr is going to share information on different types of diabetes and the technology, medications, and monitoring that it makes it easier than ever to manage this condition successfully. Dr. Orr earned her medical degree and completed her residency in internal medicine at the University of Missouri. She then completed a fellowship in endocrinology and metabolism at the University of Kansas School of Medicine. Please join me in welcoming Dr. Orr.
Thank you, everybody, and I think everyone can hear me way in the back. I can talk louder if I need to. I recognize a lot of the faces here today. Many of you come visit me in the office, and I see a lot of people here that I don't know. I know you're not here because I'm up here talking. I know you're here because what we're talking about today is diabetes. And Ms. Schmidt is right. 10% of us in this country have this disease. Now, apparently they put a new slide in here saying that I will be discussing some brand name products. I'm not promoting anything, and I think it's important to say that. I am never reimbursed for the products that I prescribe, nor are other physicians. No one is paying me to be up here speaking with you today. Just the smiles on your face are payment enough. So as we said before, about 10% of us have diabetes. This is probably going to be one of the most complicated slides that I show today, but I think it is important to understand how diabetes affects our communities and to understand there are certain ethnic groups that have more of a tendency toward diabetes, and that we need to have that approach when we talk to our patients about any disease state. When anyone comes into my office for whatever reason, maybe it's a thyroid problem, maybe it's another hormonal problem, I usually will ask that patient, does anyone in the family have diabetes? Have you ever been told your blood sugars are high? And has your doctor checked you for diabetes? Because with 1 out of 10 of us having it, I pick up a lot of diabetes in those patients. Now this is a slide that if you go to any diabetes lecture, whether it's a community talk like we're doing today or a medical talk where physicians are talking to other practitioners, you're going to see this slide. Now this is related more toward type 2 diabetes, and I'm going to talk a little bit about the difference in the different types of diabetes in a minute. But as you can see here, we're looking at 20 years of obesity records in the United States and how obesity has gone from an average of 14%, or for an average of less than 14% in most states to greater than 26% in many, many states. And you can also see that diabetes has increased in the same fashion as obesity has increased. You will notice where Missouri is with this. Missouri was kind of mid-range in terms of obesity back in the mid-90s. Today, we're one of the states that has the highest levels of obesity and the highest levels of type 2 diabetes. Now, I think it's important to look at the states where you don't see as much obesity and you don't see as much diabetes, because I think this may be a clue for us in how we can approach the risk for this disease and also to help people who have this disease treat it. Those states that I'm talking about are Colorado, Montana, Wyoming, and Minnesota. They have slightly lower rates of obesity and slightly lower rates of diabetes. Now, what do those states have in common with each other? It's not ethnic mixing. There's quite a bit of diversity in all of those states. Matter of fact, some of the states have higher rates of Native Americans and Hispanic folks who have very high rates of type 2 diabetes, yet those states have lower rates of obesity and diabetes. And I will posit to you that the reason they have that is that those states in general promote a more active lifestyle, particularly outdoor activity. And a lot of the states that led early in terms of higher rates of obesity and higher rates of type 2 diabetes are states that have been unable to promote that type of activity, or maybe have very hot climates that prevent people from being outside, particularly in the summer months, to exercise, such as states like Mississippi and Louisiana. So think about that as you're using great facilities like here at the Gladstone Community Center, how good it is to be out being more physically active. And not only do we want to spend our time in the gym, but we want to think about how we can change our activities throughout the day to add more physical activity, find things that we like to do that are not sedentary activities. So how does a doctor like myself diagnose diabetes? Most of the patients who come to see me already carry that diagnosis, but every once in a while I will have a patient who comes in and says, oh, Dr. Smith says I have diabetes, but I don't believe him or her. And so, yes, it happens. And you know what? Dr. Smith is almost always correct. But I have different ways that I diagnose diabetes. One of the ones that most of my patients are familiar with is the blood test called hemoglobin A1C. A hemoglobin A1C is not a blood sugar, but it correlates with average blood sugars over the last 3 months. And now, according to the World Health Organization, we can use this test to diagnose diabetes. So an A1C of greater than 6.4%, and a normal person has an A1C between 4 and 5.6. But if the A1C is greater than 6.4, you have diabetes. If you have 2 fasting blood sugars greater than 125, you have diabetes. Or if you have 2 random blood sugars because you went to Culver's and had a big chocolate shake, over 200, you have diabetes. You do not need all 3 of those criteria. You only need 1 criteria. Sometimes a patient will come to me and they're taking diabetic medicines for reasons other than diabetes. So for instance, I may see a young woman who takes a drug called metformin, which is a commonly used diabetic drug. She may take it for a condition called polycystic ovarian syndrome. Well, if this young woman comes in and her A1C is 6.1, which you would say is not diabetes, but she's already on that medicine, then I do believe that that patient also has diabetes. We hear on TV about pre-diabetes. I love those commercials. Some guy's sitting there talking about eating bacon, and his doctor says, yeah, I like bacon too, but you still have pre-diabetes. I think about diabetes as living on a timeline. We are born with a genetic tendency to develop the condition. As we age, as we gain weight, sometimes in women with pregnancy, and sometimes based on some of the medicines that we take, we develop more and more insulin resistance. And what that means is that our bodies require more insulin to keep our blood sugars under control. At a certain point in time, we will say this patient is pre-diabetic. And what that tells me is that statistically, within a 5-year period of time, they're about 70% likely to have overt diabetes. Now, we call pre-diabetes a fasting blood sugar greater than 100 but less than 126, or a hemoglobin A1C between 5.7 and 6.4. And this has become very important because a lot of us think that what we do when someone is pre-diabetic is going to impact how much medicine they require taking and what complications that they have. So sometimes we may just be emphasizing diet and exercise, particularly if the A1C is between 5.7 and 5.9. But with an A1C above 6, many doctors like myself think that medications, in addition to diet and exercise, need to be added. We know that those pre-diabetic patients are at the same risk for what we call macrovascular complications of diabetes as our diabetic patients. Those are complications of stroke, heart attack, peripheral artery disease in our legs. So it's very important as we're taking care of blood sugars that we don't forget that diabetes and prediabetes is a disease of the vascular system, and that's what our patients succumb to. I don't typically lose patients because their blood sugars are too high. I lose my patients at earlier ages because of heart attacks and strokes. And of course, other complications that we worry about in diabetics are microvascular complications. Those are patients who end up with neuropathy or nerve damage in the legs and end up having amputations. It's kidney damage that leads to dialysis, and it's blindness from retinopathy. Diabetes is the leading cause of blindness in adults in this country, and we know that almost every case of this can be prevented if we can impact patients early enough to keep their blood sugars under control. So let's get in a little bit to the different types of diabetes. I'm going to concentrate primarily on 2 different types, type 2 and type 1. By and by, 97% of diabetics can be put into one of those categories. So I probably won't talk very much about some of the atypical types. But the most diabetes that I see is type 2. 90% of people with diabetes have type 2 diabetes. It's the disease we used to call adult onset diabetes, but that's a misnomer because you can develop type 2 diabetes at any age. We see children now because of high rates of obesity who have type 2 diabetes. We see young adults with type 2 diabetes. Oftentimes when that happens, we do see it with very high rates of obesity. It tends to run in families. If you have a parent or a sibling who has type 2 diabetes and you are an obese adult, if you live long enough, you likely will have this disease too. Now, if you're a lean adult who has a positive family history like that, your risk is still 50%, but it's not almost 100%. So maintaining a more normal body weight and having an active lifestyle can really reduce your risk of developing that type 2 diabetes, even if you are on that diabetic timeline. Type 2 diabetes is really, like we talked about before, a disease of insulin resistance, where the body can continue to make insulin, but not as much as the body really needs. Over time, and I used to talk to patients about it being like my mother-in-law's car. My mother-in-law had a car she had for 8 years, and it had less than 20,000 miles on it. I was a working mother with 5 kids, and I had a car that I could put 27,000 miles on in a year. So my type 2 diabetic patient's pancreas was more like my car. They were overusing it. My car wasn't gonna last more than a few years. My mother-in-law's car, I think, lasted 15 years because she had low mileage. When you have insulin resistance, you're putting high mileage on your pancreas. Now, there are many treatments available for type 2 diabetes, diet and exercise being very important, as well as oral agents and some newer injectables that we're going to talk about, as well as insulin. Most type 2 diabetics, if they live long enough, will end up taking insulin at some time in their life. That is not a failure. That just means that that patient is taking care of their diabetes and not succumbed to the complications. There's lots of people with diabetes. I could have 10 different slides with faces that you guys recognize who have type 2 diabetes. I've chosen these folks here because they've talked about their type 2 diabetes and they have promoted the things that I think are important to promote, which include healthy lifestyle with weight loss, compliance with medication. Some of these people actually do work for some of the pharmaceutical companies as well to promote some of their products. Type 1 diabetes is a different disease with the same outcome, and that's high blood sugar. We used to call type 1 diabetes juvenile diabetes, but as you're going to see in a second, you can develop type 1 diabetes at any age. I see people sometimes that are over age 60 that had diabetes for a few years, and I say, I don't think you're a type 2, I believe you're a type 1, and we do some blood work to try to demonstrate that. It can run in families. If a patient has type 1 diabetes, their children's risk for developing type 1 diabetes is 12 to 15%. That being said, most people with type 1 diabetes do not have children with diabetes, and most type 1 diabetics that I see do not have other family members with type 1 diabetes. It is an autoimmune disease, and that means that the body produces antibodies that attack the cells in the pancreas that produce insulin and destroy those cells. When enough cells are destroyed, the blood sugar goes up. It's not a case of a light switch where insulin is on one day and off the next. There is often still a small amount of insulin being produced, even in people who've had type 1 diabetes for a number of years, but the pancreas cannot increase that amount of insulin to meet the needs when we eat the foods we eat. And one thing to talk about, because type 1 diabetes must always be treated with insulin. There are some medicines that are being used as an adjunct to insulin in some very specific patients, but the mainstay of taking care of type 1 diabetes is insulin. And without insulin, a patient develops a condition called ketoacidosis. And that is a condition where the body breaks down fat and muscle to produce something called ketone bodies that the brain can use as an alternative fuel. It is a fail-safe that we have as humans for a time of starvation so that the brain can continue functioning. The problem is, in a type 1 diabetic, they can't turn that system off. And so ketone bodies build up and are acidotic, and then that patient ends up at our fine hospital in North Kansas City, where he or she is taken care of by very fine doctors in the intensive care unit on an insulin drip, and that's not what we want. Prior to the development of insulin for treatment of type 1 diabetes, ketoacidosis is why type 1 diabetic patients die of their disease. And there's a lot of people out there with type 1 diabetes. Mary Tyler Moore is probably the most famous one that you all will recognize. She was one of those folks that developed her type 1 diabetes at an older age. And I believe ultimately she succumbed to some of the complications of that disease. We have professional athletes like Jake Cutler. I never know which Jonas Boy that is, and I never really know what those Jonas Boys do, but he has type 1 diabetes, he wears an insulin pump, and my understanding is he's pretty active in treatment of type 1 diabetes and promoting treatment of the disease. And as well, Sonia Sotomayor has type 1 diabetes, and again, my understanding is she's been very active in her treatment. So how do we manage diabetes before we get into some new products? This is the mainstay for both type 1 and type 2 diabetes. And monitoring. I cannot say enough about monitoring on diabetes. Having that blood sugar meter with you all the time so that you can check if something is unusual is what's going to make a difference in your health, your life, your safety, and even your family's safety. We monitor for 3 reasons when we have diabetes. 1, so that the changes that I make or your provider makes based on those blood sugars are safe and effective. I cannot look at just an A1C and make a decision about what is best for my patient. I need to look at those blood sugars. 2, so that you can see how the food you eat affect your blood sugars so that you can make reasonable choices. That's why when I see a patient who may even not be on a lot of medicine, I recommend that they monitor more than once a day. If a patient brings me in a blood sugar log that shows blood sugars first thing in the morning, I say, well, that's lovely, but that only tells me what happens before you eat. I need to know what happens later in the day as well. So I do encourage any diabetic, even if they're just monitoring once a day, to alternate times. Check with their provider to see when they want it done. An endocrinologist like me may be a little more aggressive testing than a primary care doctor, but I do think at least monitoring in the morning one day and then maybe before supper or bed the next day is a better choice than always just monitoring in the morning. If you're uncomfortable skipping that morning monitoring, fine, do that again, but that'll be a day that you monitor twice. The third reason you need to monitor if you are on insulin or on certain oral medicines that can cause low blood sugar is to protect yourself from life-threatening low blood sugars. Unfortunately, I've had several incidents in my career where I've been called by highway patrol to be told that one of my patients has had an accident and that it might be the result of a low blood sugar. You should know if you're on insulin or on a class of drugs called sulfonylurea, how your blood sugar is doing before you get behind the wheel of a car. Many diabetics cannot tell what their blood sugar is by how they feel, particularly the longer you have the disease. We see a fair amount of what we call hypoglycemic unawareness. And for the patient who comes in and says to me, oh, I can tell if my sugar's high or if my sugar's low, I'll tell that patient you're wrong 50% of the time. So that monitoring is very, very important. Medications. We're going to talk a lot about medications here in a minute, so I'm not going to get in depth. But compliance with medicines is essential. Or letting your provider know if you're having trouble with medicine. So I may look at somebody's blood sugar, I may make an assumption that they're taking their medicine. The patient may be embarrassed to tell me that they're skipping 2 of their shots a day, and I may say, gosh, you need more insulin, so I may increase that insulin. And that may be okay as far as the patient thinks because he knows he's not been taking his medicine, so he can accommodate that. But if that patient is put in a position where they go to the hospital for something, maybe they can't speak for themselves for some reason, and somebody calls and says, what has this patient been taking? And I say, oh, well, this patient takes 30 units of insulin with each meal and 100 units at bedtime, but that patient really isn't doing that. And then the other person says, okay, well, that's what we'll start again. We can cause some big problems. So compliance and discussing with your provider about your medications, concerns you have, worries about side effects, very, very important. I also urge my patients, if you are going to stop your medicine, please call and let us know. That may be a good choice, but it may not be a good choice, or we may want to do something else. So please keep your provider in the loop and try not to do this on your own, particularly insulin dosing. Diet and exercise, isn't that the hardest thing for all of us to do? We have rates of obesity in this country that exceed 26% of the population. If that was just because we weren't motivated or just a little bit lazy, well, we'd all be skinny. But we're not. And so we don't have a good grasp on problems of obesity in terms of why we overeat. I personally believe it has to do with brain chemistry. I think we're going to have to work hard on that, but food is very abundant. We still have the same brains our prehistoric ancestors had. And our prehistoric ancestors didn't have food available to them all the time. And so the ability to overeat when there was abundant food could be life-saving, because then they could store some energy for that day when the hunt was bad or they couldn't find enough with their gathering to eat. But today there's a quick trip in a McDonald's on every corner. And relative to how it used to be, calories are pretty cheap. Good nutrition may not be, but calories are cheap. And we do tend to overeat. Also, we live in a society where we don't need to exercise very much. My washing machine is on the same floor as my bedroom. It's 2 steps out to my garage to the car. Heck, I push a button to open my garage door. I don't even have to lift it myself. I'm fortunate I've got a good parking space at my office. Sorry about that, my patients. I know you don't. But most of us can get through our day with very minimal physical activity. So in order to get our exercise, we have to be purposeful about that. And we as a society are not very good. As a culture, we don't build our neighborhoods to encourage exercise. When I was a little girl in a small town in Iowa, if my mother needed some milk, she handed me some money and I walked down Main Street to go to the little grocery store and I would get milk and walk back home. If I want to get milk today, I have to get in my car and drive a couple of miles, because that's how my neighborhoods have been built. We're not near shopping like that. For a long time, it was sometimes hard to find sidewalks in some neighborhoods to walk in. So we need to be very purposeful about our physical activity. Regarding education and information, obviously you folks are interested in this because you're here listening to me yammer on today. But I know of no other disease process that what the patient knows is as important as what the provider knows. If I'm a cancer doctor, I need to know all about the medicines I use, but the patient doesn't need all that information. They may like that information, but the provider needs most of the information. In diabetes, what you know, because you are so complicit in this disease process as far as taking care of yourself, that you've really got to remain educated. I really believe that a patient really ought to get to some kind of an education class every couple of years, just like I go to education every year, because I don't want to practice medicine like I did 5 years ago. And I would like my patients to not practice diabetes care like we did 5 years ago. So I do think the education is very important. The problem with education and information is there's a lot of it out there. And some of it's very, very good, and some of it's not so good. And sometimes it's a little hard to tell the difference. So we'll talk a little bit about that as well. So let's talk about monitoring. That's the first with some of the new stuff that I'm going to talk about. I'm sure most of you are familiar with glucose meters. They're just a point of reference. What's my blood sugar right this moment? And most diabetics use these devices, or should be using these devices. We also have now continuous glucose monitoring, and that is a device that a patient plugs into themselves that will give a continuous running glucose. Continuous glucose monitors are often used with insulin pumps, and they can warn patients if they have high or low blood sugars. There's some positives and negatives about using them. but that's one thing we have that we can do today. And I also want to talk a little bit about flash monitoring. You folks have seen advertisements for an available flash monitor, and I think you might be interested in this. So glucose meters are getting smaller and smaller. There are some that you can actually plug into the top of your phone and use. They're taking smaller drops of blood. The fine little needles we poke our fingers or our arms with are tiny. Most patients who've had diabetes for a long time will tell you that it's much more comfortable to test your blood sugar today than it was 10 years ago. Do you know, I remember before patients started monitoring their own blood sugars, because the self-monitoring started taking place in about the mid-'80s. And I was a medical student getting ready to graduate then, and I remember a professor who actually still is a professor in endocrinology today saying, I don't think patients will be wanting to do this. I don't think they'll be willing to do this. And yet, I have a room full of people today that I bet a lot of you do monitor your blood sugar. So we were very glad to prove him wrong. Some of the pumps will talk to your cell phone now, that there are apps you can use to transmit that information. And so I have a lot of patients during the day that just hand me their cell phone and say, here's what my blood sugars are. They can be downloaded to your computer. There's information that you can add to that. I like to see a patient actively looking at those blood sugars, not just collecting them for me. I want them to look at it and say, oh gosh, look, when I go out to dinner, look what happens to my blood sugar. Or look at that low when I went out and painted the garage in the backyard. That really helps a patient make some decisions about physical activity as well as dietary changes, and can help me help them as well. I mentioned Amazon and Walmart here because we have to talk a little bit about price today. I bet you everybody knows that diabetes is an expensive disease to have. And 10 years ago, most of my patients could get meters and meter supplies for the lowest copay on their insurance. And it's not the same today. Some of my patients will have high dollar values to get testing supplies through their insurance. And I always encourage them, if you really feel like this is too pricey, Walmart has a meter called a Rely On. Not necessarily my favorite meter, but it's better than not testing, and the strips for that meter are 18 cents a piece. And I do have some of my patients that get some of their testing supplies through Amazon, even though in either of those cases it's not going through their insurance, it might be cheaper. And I do encourage people to look at all of those possibilities. Here's some of the meters we use. That up on the upper right, that's that Rely On meter. All of these are fine meters that will give us accurate readings. All of the meters on the market today will keep a record of the blood sugars. The problem is, on any given day, about 30% of the meters I see do not have an accurate time and date. So if you can't keep an accurate time and date, I would like to see a log of those blood sugars, as I'm sure your provider will too, because that can make a difference in how I change your medicine. I need to know when those are being done. There are instructions on all of these how to change time and date, and if you bring your meter into the office, I usually can do that as well, but there's lots of help available. And some of the bad points of having to get a blood sugar reading is that it requires obtaining blood, and it hurts. And I have some people who say, oh, no, it really doesn't hurt that much. I am sorry. I have been taking care of diabetics for decades now. I poke my finger all the time. I hate it. It hurts. And I know I'm asking some of my patients to do that 4 times a day. It is just a single point of reference. So it's like taking a snapshot of one of your pretty faces. This is what you look like right now. This is what I look like right now. If you had seen me and taken a picture of me at 6 o'clock this morning, my hair would have been a mess. I'd spilled coffee down my robe. And I had my knitting in my hand. It's different at different times of days. So in order for finger stick testing to be good information, we need multiple tests. Continuous glucose monitoring. And once again, these are used usually with insulin pumps. They are an insertion device that you see like on this lower left side that sits in the skin for a certain period of time, days and days and days, and it transmits a reading to one of those little boxes. And it will continue to do that throughout the day. It will warn patients if their blood sugars are running high or low. So for instance, let's say you're somebody who travels for a living and you're a type 1 diabetic, and one day you wake up looking into the beautiful blue eyes of a paramedic because the hotel maid has found you unconscious because you had a low blood sugar. Well, your spouse is never ever going to let you travel alone again unless you do something. And so the continuous monitor can be very, very helpful for those patients. Also, because it gives us an indefinite number of points of reference, we really can see what's going on. If you're testing before meals and bedtime, we're not seeing what's happening 2 hours after a meal unless you poke again. But with a continuous monitor, we can see those things. So, like I said, it tracks sugars throughout the day and will give us alarms. There is a new device, a new continuous monitor. Medtronic makes this device that actually talks to the insulin pump. Now, an insulin pump is a device that contains insulin that dribbles a little bit of insulin in all the time, and then at meal times you tell it to give you more insulin. That little bit of dribbling insulin is what we call a basal rate. And the new continuous monitor will self-adjust the basal rate, making this more like the body's own pancreas and hormonal system. And it's allowed for smoother blood sugars with less hypoglycemia. And we really like that device. The newer devices for all of the companies also limit the number of finger stick calibrations you need to make. With most of the continuous monitor devices we see today, you've got to, because the monitor is not actually reading blood sugar, it's reading something called interstitial fluid sugar. You have to poke your finger and tell the device what that value is so it can interpret that. But the newer devices require much less calibrations. And these are some of the insulin pumps that we use. I won't talk too much about insulin pumps today. I just mentioned them briefly. There's several different ones on the market. Often the pump we use is the pump that's covered by somebody's insurance. Probably our most popular device is the Medtronic device down on that lower corner. The device above that is called an Omnipod. It is a tubeless pump. So there is no tube that connects from the insertion site to the black box. It's a wireless setup, and a lot of patients like that. As I said before, an insulin pump administers a small dose of insulin continuously and acts more like the pancreas. It allows for just one needle stick every 3 days rather than 4 shots a day, and we are better able to rapidly adjust things. So for instance, if we put a basal rate of insulin in, let's say 1 unit an hour, as opposed to giving a bedtime insulin shot of a 24-hour insulin, like insulin glargine or Lantus, and gave that person 24 units, well, let's just say the next day a patient gets up and a friend comes over and says, hey, let's go turkey hunting. And you know that turkey hunting means driving out to a field where you walk a couple miles, schlepping your guns and all your other paraphernalia, and then you've got to walk back. And if you get a turkey, you've got more walking you've got to do. And then the last time you did that, you had problems with low sugar. Well, you can turn the insulin down on your insulin pump. You can say 1 unit an hour is going to be too much for me. I'm going to cut that back to half a unit an hour. Whereas if you're taking shots, you can't take away the shot you took last night. Flash monitoring. This is something I'm really excited about. And I confess I use this a lot in my office. You've seen advertisements for this on TV. that little black box that lady's holding, she's just waving it in front of the device and it's reading her blood sugar. And it doesn't matter whether she does that 4 times a day or 400 times a day. There's no strips involved and there's no additional cost. That little patch you see on her arm is worn for 2 weeks at a time. And if she checks her blood sugar frequently enough, it will also give us a continuous reading. And so I think that this is where we're going to be going with monitoring if you're not talking about the standard continuous monitor. I really think 5 years or more from now, nobody's going to be poking their finger. They're going to be using devices like this. And I think this is very exciting. There's no finger stick calibration. You just plug it in and after an hour it starts working and off you go. Now, some disadvantages. It does not alarm you for highs and lows. So like the point of care glucose monitor, you've got to know to check it to see what your blood sugars are running. At this time, because it's relatively new on the market, it's not being paid for very well. Most of my patients have to pay a fair amount of money to obtain this. And it does not connect or talk to other devices, though I understand that's kind of in the works. Now let's talk about medications, because I think that's something that most of you are here to hear about. The medicines that we use, and we'll talk about, are insulins, oral medications, and other non-injectables. A lot of people think that if you're giving a shot, it's always going to be insulin, but in fact, that's not the case. Insulins, probably the biggest thing I have to talk about insulin is that we have more competition now with long-acting and short-acting insulins. Our hope is, I have my fingers and toes crossed, that this competition is going to mean that prices will fall. We have not seen that yet, as many of you know. I know Lilly Insulin just said they were going to rebrand their Humalog, calling it a generic and slashing the price in half. Since it's the very same thing, I don't know why they just don't slash Humalog's price in half, but I guess I don't work for Lilly, so I don't know. But that's probably the most important part. The insulins we have now work more like the insulin in our body does. Old-fashioned insulins like NPH and regular insulins have kind of longer durations of action. It can be more difficult to use than the more commonly used insulin analogs now. I do want to talk briefly about inhaled insulin. That has not been very popular in many communities, including our own. Many, many years ago, Pfizer Pharmaceuticals had an inhaled insulin product, that's the one on the lower right, called Exubra, and it was not accepted at all. People didn't prescribe it, patients didn't use it, and it's off the market now. That tube you see there, it was a bong that was about this tall. And it was just difficult to imagine a patient doing their inhalation at the restaurant. Just very, very difficult. Now we have a new product called Frezza, and you can see how small that really is. You have kind of limited doses you can use in it. It also must be used as only the short-acting insulin, so most patients still need to take long-acting insulin. And you have to have very good lung function, so you have to undergo lung function testing before you start that product, and you have to intermittently undergo lung function testing while you're using it, because the product does show some decline in lung function, which is, I believe, why most doctors in the area have been very slow to accept this as an acceptable means of treating diabetes, but it is available, and I would encourage, if you're interested in it, that you talk to your provider about it. Oral medications. We have some nice drugs that are generic, such as metformin and some of the sulfonylureas, and lots of new branded drugs. There's many different classes and actions. Because we have so many different classes, it gives us the opportunity to combine drugs. When I was that young medical student, again, there was only one class of oral drugs, and if you failed those and they were sulfonylureas, then you had to move on to insulin right after that. Now, I often have patients on 3 non-insulin medications before I ever even think about starting insulin on patients. Many of the newer medicines don't promote weight gain or low blood sugars, and that's a huge advantage. Matter of fact, some of them even will promote a little bit of weight loss, and they work very well in combination with each other, oftentimes not causing low blood sugars. So older drugs are sulfonylureas. They cause the body to increase the amount of insulin they make. Those drugs may be glimepiride, glipizide, glyburide. Many of you still may be on some of those medicines. They promote weight gain and they can promote low blood sugars, but they're very, very effective. They're very cheap and they still have a place in how we practice today. Metformin is the first drug usually prescribed to diabetics. By the way, my Facebook says doctors are not prescribing metformin anymore, and yet we are. And so you gotta be careful with that Facebook stuff. Actos and Avandia are also generic products. They tend to promote weight gain. We tend to use those in people that it would be very detrimental to go on insulin. So if you're an over-the-road trucker, you may lose your job if I put you on insulin. So then I will reach for Actos and Avandia, even though I may think that there are better drugs or that they may have some unacceptable side effects that I don't like in some of my patients. Precoz and Starlix are drugs that work within the GI system. They're not very commonly used these days. They tend to cause some GI side effects that some people find intolerable, and they're not very potent. So we don't see that very often. Cycloset is one that I see that they're trying to promote a little more now. It's an old drug called bromocriptine that's been reformulated that works on the dopamine system in the brain and seems to have some effect on blood sugars. Newer drugs, DPP-4 inhibitors. Now these still have been around for a long time. They've been around for over 10 years. You may know them, Januvia, Onglyza, Tradjenta. They do not cause hypoglycemia. They affect another hormone that increases blood sugar called glucagon. They are safe for the heart. They are weight neutral drugs when used alone or with metformin, don't cause low blood sugar reactions. They're very expensive. And despite the fact they've been around for a while, I still have patients coming in and telling me that these are expensive drugs and they really can't afford them. Some insurances cover them well though. They should not be used if you have a history of pancreatitis or you have triglycerides over 500 because that can cause pancreatitis. In general, I use this class of drug because it's safe for most systems in somebody who needs a little bit more help than they already have. So an older patient on a lot of different medicines, it may be a good candidate for this drug, these drugs. SGLT2 inhibitors, and you guys have seen lots and lots of advertisements for this. Farxiga, Invokana, and Jardiance. Jardiance's new advertisements are, we're healthy for the heart. They've even almost stopped talking about what it does to the blood sugar because they're so excited about their heart data. And yet we find they're very good diabetic drugs. And we're happy that if a patient has a cardiac history, we can safely use these medicines. These medicines work by causing you to get rid of extra sugar through your urinary system. So you are peeing away sugar. Well, when you pee away sugar, you pee away calories too. And so we sometimes see some weight loss with these. Once again, these are not generic drugs, so they can be more expensive. Most insurances will cover one of these medications pretty well. It can have an effect on the kidneys if you allow yourself to become too dehydrated. And because its mechanism of action is the kidney, you have to have pretty good kidney function for these drugs to work well. So we do tell people to increase their water intake by 4 glasses of water if we put you on one of these medicines. It can increase your risk for yeast infections and urinary tract infections because of sugar going through that system. Now, you'll see we've got increased risk of amputation undetermined. That applies to only one of these drugs. Invokana, the first one that was on the market, was doing studies to prove that they had a cardiac benefit like Jardiance did. And they did prove that cardiac benefit, but they saw a small increased risk in amputations in the patients that took those drugs, and that was seen in 2 studies. None of us can explain that. We don't know what it means. It's a very small increase, but the other drugs have not demonstrated that. Does that mean I don't prescribe Invokana? No, I do prescribe it, but if you have problems with nerve damage in your feet, or you've had an ulcer, or even a previous amputation, then that's not the drug I'm going to choose for you. And the reason I mention that is because you'll see warnings about that. You will also see warnings that these drugs might increase your risk for that diabetic ketoacidosis. We're not sure again why that happens. Some of those cases appear to be in people who were probably type 1s that were misdiagnosed, but there are some cases that we say, no, this was a type 2 and they developed ketoacidosis. So if you're given this drug, your provider may caution you. If you start developing nausea and belly pain, give us a call and they may want you to have your ketones checked. I have not seen ketoacidosis with these drugs, but I do know it exists. GLP-1 agonists. These are the injectable drugs that are not insulin: Bydureon, Byetta, Ozempic, Trulicity, and Victoza. Three of them, Bydureon, Trulicity, and Ozempic, are once-a-week injections. Byetta and Victoza are daily injections. They have three mechanisms of action. One mechanism of action is the effect on glucagon, like the Januvia and those drugs were. They lower glucagon so that blood sugar is down. They also slow down the absorption of carbohydrates from your intestinal system so that you don't get a big rush of glucose coming into your system. And they also have an effect on the brain chemistry to reduce appetite. As a matter of fact, one of the drugs, Victoza, at a very, very high dose is used as a weight loss drug. So these drugs promote weight loss. Again, they can be expensive because they're not generic medications. Used alone or with metformin or the SGLT2 drugs like Invokana or Jardiance, they will not cause hypoglycemia. GLP-1 drugs can cause nausea. Sometimes the nausea is severe, so we start with a low dose and increase it. It also can cause constipation because your gut is slowing down. With this class of drug, there is a concern because in animal studies, they have seen an increased risk for a certain type of thyroid cancer called medullary thyroid cancer. We have not seen that in humans, but if you listen to the advertisements, they will say that there could be an increased risk. Like the DPP-4 drugs, you cannot use these with pancreatitis or high triglycerides because of an increased risk in pancreatitis. I have seen that happen, and it's not very fun. And these are pictures of some of these. The needles are teeny, teeny tiny. They're like the little insulin needles we use. Most people, the Trulicity itself, the needle's actually hidden. Most people will say they can't even feel it at all. Now, I can't forget diet and exercise. I have a nurse practitioner in my office, and she bullies me a lot. And she said, you better be sure that you're talking about diet and exercise when you talk about new stuff. And I said, yes, Janet, I'll talk about it. It's got to be individualized. The diet that's right for me, is not the diet that's right for my 20-year-old college student who's an athlete. And it's not right for the 80-year-old little lady that's coming in to see me next. So you really have to take that into consideration. So if you go to a diabetes education class and everybody ought to get 45 grams of carbohydrate and everybody ought to have this same meal, that's not really individualizing things because that young man needs a whole lot more than 45 grams of carbohydrate. Now, we really want you to have 3 meals a day. We want you to have breakfast, lunch, and supper. We want those calories spread out through the day. You will have less of a tendency to overeat if you do that. Also, you're on medicines that don't know you like to skip breakfast. So those medicines are going to be effective then. But if you overeat, you may not have enough effect from the medicine. So we want you to eat 3 meals a day. I know that right now, something called intermittent fasting is really, really popular. I tend to disagree with that, and as a matter of fact, one of the big heart journals just published an article that said if you skip breakfast, you're 80% higher risk of having a heart attack. So I really like the 3 meals a day, and I do not want my patients on medications to do intermittent fasting. We would like a balanced, nutritious diet. I have people who come in to me and say, oh, I don't ever eat any carbs. Let's think about what carbohydrates are. Carbohydrates are plant-based foods. They are fruits, they are vegetables, they are grains. There's nothing wrong with any of those things. It's when we overeat that it makes a difference. In healthy diets around the world, 50% of calories are obtained from carbohydrates, but they're healthy carbohydrates. They're not Oreos, they're not having cheeseburgers and French fries. You know, they're healthier foods. So I do encourage people to do that. If you think about it, if somebody is on a 2,000 calorie a day diet, which for a moderately active middle-aged adult is a reasonable amount of calories to eat, 1,000 of those calories should be from carbohydrates. I've done the math. It's about 200 grams of carbohydrates a day, so it's a little more than 60 grams of carbohydrate per meal. Those are reasonable numbers. You don't need to go lower than that for health. I do want to talk just briefly about education, and I'm making fun of a few people here. I think if you like to watch Dr. Oz, who I understand is an excellent cardiothoracic surgeon, but sometimes they talk about and promote some things that are kind of goofy. So if you see something on a show like that, I'm picking on Dr. Oz, but it could be any TV show that you see out there, take it to your provider. Trust your provider to understand that information and be able to explain to you whether the information you're getting is good information or bad information. Dr. Google. There is not a day that goes by that if I don't walk into a room and a patient says to me, you're going to be mad, but I Googled this. Well, I Google everything. I'm never mad if a patient Googles something. That's just the nature of things. But learning on the internet what appropriate information is and what inappropriate information is very, very important. Remember, when you Google something, oftentimes the first few things that come up are things that people have paid to be at the head of the queue. They can often be advertisements. They may be promoting a product. Those are the things you've got to look at very carefully and say, I don't know about this. Group chats. You're talking to other people that have a bias, they have an agenda, they don't know you, they're not taking care of you, they don't know your medical history or the medicines you're on. Getting advice from group chats is not a good idea. Once again, taking those ideas to your provider can be very, very helpful. Same thing with Facebook. I talked about metformin and Facebook. Because I've looked at something regarding diabetes on my computer, now my Facebook pops up all sorts of diabetes stuff. And I will tell you, just like trying to get your political information from Facebook, please don't get your medical information from Facebook. So where should you go? I think there is good sources out there, and some of these look like they might be kind of complicated, but most of them actually have good patient sites that will give you good, reasonable, legitimate information. And I have no objection. If you want to take a photo of that slide, please feel free to do so. I find the American Association of Diabetes Educators to have excellent, excellent information that's easy to read. The ADA as well. All of these are very, very helpful. If I'm looking up a disease state and it's got National Institute of Health as its tagline, I know I'm getting good medical information. So those are the things that I encourage people to do, as well as please talk to your various providers. Thank you.
Thank you.
I think we have just a few moments for questions. things, and we have some microphones that people will bring to you. And so if you raise your hand, somebody with a microphone will try to find you. I've got one up here in front to start.
One person always starts and then there's a tidal wave. Thank you, Briggsel.
How do you get the 3-month test that you were talking about, the A10C or whatever that was? Does your doctor order that?
Your doctor or your provider, maybe your nurse practitioner may do that. It's a very common test.
Do you have to,
Oh, I'm sorry, go ahead.
but do you have to go and have your blood tested several times over that 3-month period?
No, it's just one test.
Oh, okay.
And many providers actually will do that as part of a comprehensive lab panel these days. Or you can specifically say to your doctor, I'm worried about diabetes and I have an A1C done. In my office, we do an A1C with a machine that allows us to do a finger stick device.
Okay, thank you.
I did testing my sugars 3 times a day. I'm sorry.
You are fine.
And for strips and standards, this, that. I was informed that I could no longer get 3 tests a day. I could only get 1 test per day because I wasn't on insulin.
So let me talk about Medicare and payments about this. That's an excellent, excellent question. Medicare has, and this has been the rule for a long time, this is not new, but all of a sudden we're getting a lot of pushback again. Medicare said that there's no pushback if someone not on insulin has a prescription for 1 test a day, if they're on insulin 3 tests a day. If your provider wants you to test more, there is a certain amount of paperwork that needs to be done. So for instance, if I see a patient and I want them to test twice a day because they're type 2, I have to say what type of diabetes they have, I have to say why I think that has to take place, and I have to say how long it needs to take place. Same thing with my patients on insulin. Recently, I don't know what Medicare and the pharmacies have had. I think some of the bigger pharmacies have gotten into a little bit of trouble with this. But all of a sudden, we're hearing from some pharmacies, I don't want to pick on any, but Hy-Vee is one that comes to mind, that have said, we don't care if your doctor wants you to do that. If your doctor wants you to test more than 3 times a day if you're on insulin or more than 1 time a day, you will have to go elsewhere to get your strips. And I don't like it. I don't think it's the right thing for a pharmacy to do, but I also understand that at their end, the cost of having to do their extra paperwork and the Medicare audits that take place with that have become very, very onerous. My recommendation, and that I tell my poor legislator people, they probably think I have their address on my Rolodex, because about once a week I fire off an email or a letter saying, please consider this. But the louder we are talking to our legislators saying, why are you picking on our older folks with diabetes? This is an important disease and we need to test more and all of that. And so I do recommend, whether it's Claire McCask, well, it's not Claire anymore, but whoever your senator is now, or your congressperson, let them know. Be mean, be polite, but let them know that this is an important issue and that there's an election coming up.
Can I come to your office and get that paperwork done?
Well, it's gotta be done by the physician who's prescribing it. And it's not a specific piece of paper, it's information that flows between the physician and the pharmacy. But we do that routinely in our office. We try to include that information when we send a prescription. But unfortunately, because some of the pharmacies are choosing not to participate with that, we just have to tell our patients that they should go elsewhere. A lot of our patients get supplies through some of the durable medical goods companies, like Edge Park and Solera, with some success, some not so success, but that's an option for folks. Last but not least, I always tell folks that rely on meter, those strips are 18 cents a piece.
thank you for coming and speaking to us. It's a lot of unknown answers in that. I've taken other classes too on diabetes, and they tell you to look at your labels and everything and that. And the last class I took, it did not ever mention really carbs. They were concerned about fat. So can you kind of elaborate on that? And then also, you hear about so many different types of diets like ketos and all that.
Right.
Is there some we should kind of stay towards or against or whatever?
Okay.
Thank you.
First, when we talk about carbohydrates, fat, or proteins, those are what we call macronutrients. And all food is made up of one or more than one of those macronutrients. All three groups are necessary for good health. Carbohydrates will often look like it's got a fairly immediate effect on blood sugar, and insulin is needed for carbohydrates, but insulin is also needed for protein and fat metabolism as well. So we really have to take a look at all three of those things. And when we look at our type 2 patients, the first thing I talk to patients about is calories, because that determines what we weigh. And if you are gaining weight, you are taking in more calories than your body needs, whether they come from protein, fat, or carbohydrate. Now the catch with fats is fats have twice as many calories per gram as carbohydrates or protein. So the example that I give my patients when we talk about fats is, let's all go to lunch today. I'm taking you all to Subway. And we're going to have a small turkey sub with no cheese or mayonnaise on it. You can have some vegetables, maybe a little Dijon mustard, and you're going to have a bag of baked chips and a Diet Coke. There are 70 grams of carbohydrate in that meal. There are only a few grams of fat in that meal, and the rest is protein. And it's got about 450 calories in it. Remember that 70 grams of carbohydrate? Now, I'm not a big Subway fan. I'd rather go to McDonald's. And so we're going to all go to McDonald's, and you're going to have a quarter pounder with cheese, a small bag of fries, and a Diet Coke. 70 grams of carbohydrates there. Almost 1,000 calories. And the addition in those calories is the high fat. Over 50% of that food's calories is from fat. So we do need to pay attention to all three of those things. And if you go to a nutrition talk and all they want to talk about are carbs, and they don't talk about fat or protein, or if all they want to talk about is fat and not talk about the other two, then you're probably not getting a complete picture.
And this is where I have to be the bad guy and say we've got time for one more question.
I'm on the door prize. I understand that at some point metformin was being used for people in pre-diabetic state, and then as they progressed, other things happened. But then if they got control of their blood sugars and they fell, then they would technically not need metformin. But the question I had, because I understood that if you start metformin, you cannot stop it. And I wondered if that was a true statement. I've never had anybody I could ask.
No, that's not a true statement.
Okay.
I've stopped metformin on many patients. So a good example, well, two examples are a patient who comes in that for some reason is able to do what I want them to do with weight loss through diet and exercise. There's a point in time I take them off all of their diabetic medicines. Or another case is a patient who has bariatric surgery, which is an excellent way of helping to treat diabetes. We cannot forget about that frankly, when it comes to weight loss, my bariatric surgery friends do a much better job than I do, and oftentimes in a safe, effective manner as well. I think we have some really good ways of helping our obese patients get better, but to that end, yes, you can stop metformin. I use metformin for prediabetes all the time in patients, and will continue that even if their diabetes progresses and I add a second medicine, I continue the metformin. Okay, thank you very much, Mr. Baker.